Yes, good evening. My name's Dr. Shane Higgins, and I've been a director at Queensland Fertility Group for some 20 years now, practicing infertility, and it's my pleasure to have your attention this evening to talk about secondary infertility. Before I go on, I'd just like to tell you a little bit about myself. I'm one of the team of fertility specialists at Queensland Fertility Group, and I do have the great pleasure of not only help creating lives, but also delivering the babies at the Mater Mothers private hospital. So I go from conception through to sort of delivery for the same patient, and I think a lot of the ladies do appreciate that continuity of care. Where do you find me? I'm at the little Edward Street Spring Hill offices, 55 Little Edward Street Spring Hill, at Queensland Fertility Group Central in Brisbane. And I do have a Facebook page as well, so you can find me there as well. My talk this evening is about secondary infertility, and with that, what is secondary infertility? These definitions are often medicalised and don't really mean anything to the individual. So I really do hope that this doesn't box you in any category, because I think a mother wanting to be is a mother wanting to be. That's it. How do we help you? Come and see me. But secondary infertility medically is defined as an inability to become pregnant or to carry a pregnancy to or even close to term, but it might often be that you might think this isn't very common, but actually represents about 50% of infertility cases. So it can be quite common. What are the actual causes of secondary infertility? Well, quite often they are similar to primary infertility, which is a main cause of the not being able to be pregnant the first time. They can be due to ovulation disorders, being too heavy in weight, your age may be advancing and that is consequent with fertility decline, and there may be a recurrence of endometriosis, or there might be sperm disorders now that have arisen since child number one. And there may be issues or concerns with the pregnancy or prior to delivery issues in the past pregnancy. So we would talk to you about that as well, and discuss that further. So what can you do about fertility, secondary infertility? And I'm sure there's a lot that's been going on in your lives that has helped you sort of get to this point, and that you've done things like ovulation prediction kits, and tried to track down your ovulation more precisely. So that's something you can do before you come and see me. Have you got your weight optimized? A BMI of less than 30 is optimal for not only improving your fertility, but also improving your pregnancy outcomes as well. So having a healthy weight through a healthy diet can be really, really helpful for both fertility and pregnancy. Take stock of lifestyle issues, getting smoking out of your life, having 1 to 2 only standard drinks per day, not getting too heavy on that, and any other illicit drugs then have to be out of your lifestyle. Certainly it's a couple thing getting pregnant, and so making sure your partner is part of the solution and not part of the problem. His drinking and or smoking can have a negative impact on his sperm function, and so he wants to get a healthy lifestyle with 1 to 2 standard drinks and no more per day, with alcohol-free days during the week as well, to optimise his fertility chances and optimise his sperm counts. So certainly I've spoken about things to consider first, optimising your health and well-being, optimising your weight, optimising any dietary issues that you may need to take into account. The next step is to think about what can you actually expect from getting pregnant per cycle. And I think if you know a little bit about what the chances are, can be very helpful. You've only got probably a 20 to 25% chance of falling pregnant per cycle, even in the best of situations. So if you actually think about it, let's say 20% because it's easier to work out, 1 in 5 couples are only pregnant per cycle. So it means that if 5 couples are trying each month, 4 out of those 5 couples will not be pregnant at the end of the month, where 1 will. So the success rates aren't that high, and beating yourself up after 1 or 2 attempts at falling pregnant is can be sort of a bit harsh on yourself, and that's the way thing could be an issue. Certainly, if you're having issues with your job, or your partner has an issue with a job, stress can have a negative impact on your fertility, both in ovulation disorders and sperm function. So what you want to do is have some sort of stress management plan if you have a highly stressed job, so that you can have some downtime from that job, or resurrect or sort of maneuver into a I think my daughter says, pivot into a different position in job, so you can actually have a little bit less stress in your life. So that's could be very helpful. Certainly, basically in 2018, if you've been trying to conceive since 2020, that's 2 years now. And 2 years is a very long time for a couple not to fall pregnant. My advice is simple. If you're under 35, you should come and see us after trying for 12 months. And you can come sooner if you wish, but under 35, around about 12 months. If you're over 35, then you should come and see us after 6 months. So I would think that if you've been trying all that time, then there may be an issue. I hate to throw statistics at you, but sometimes it's helpful. After 2 years, 92% of couples should be pregnant, of those who are going to fall pregnant. So you're in the bottom 8% of your cohort of falling pregnant. So if we treated only 8% of the population for fertility issues, we'd be less busy, because we treat about 1 in 6 couples for fertility issues. So you certainly fall into the category of needing treatment. Diet in fertility is important. A low GI diet is very, very helpful for decreasing your sugar intake and getting a healthy BMI. So I think rather than going on any special diet, then having a healthy BMI below 30 is extremely helpful, and getting some exercise and de-stressing management in your lifestyle is very, very helpful. Certainly with that, then in studies it doesn't actually show a big difference, but if I said to my patients, what's the one thing you could do remarkably that would help your fertility, is to be de-stressed. Come and see me when you're sort of less stressed in your life. And certainly I've just got a question here about non-medical approaches to such as relaxation, meditation, things that can cover our chances of falling pregnant. We do have Shen Therapies is a good acupuncturist who works in conjunction with our IVF procedures, but works alone as well, and he quotes very high success rates with his acupuncture techniques, Shen Therapies, and I think he's very positive about his results. I'm not sure we can get our IVF results as high as his acupuncture results, so I do think that he is a bit optimistic in his results. So, but definitely worth trying, and if it decreases your stress and gets you more sort of in the window for success, then I think that's very helpful. And certainly with the process of falling pregnant at 25, then you definitely should be pregnant after 2 years, and I would think that with that, then you definitely need to see someone. When we do see you, we certainly do a workup to work out what's going on, and the most important thing that we actually do in the first array of tests is to look at your ovulation, make sure you're ovulating. So often we'll do a timed ultrasound scan and a blood test to make sure that you are ovulating, and so that's a day 12 blood test and ultrasound scan. Doing a hormone screen to make sure your hormones are all okay, doing an infectious disease screen to make sure you are ready to be pregnant, to make sure that the rubella immunity is there. So there's a whole panel of preliminary tests that we do, which is just one blood test when you come in to see me, an ultrasound scan on day 12 of the cycle, and we can virtually work out whether or not ovulation is an issue. Secondly, we look at the uterine environment, make sure that the ultrasound that we do on that day shows a thick and a healthy endometrial lining, which will receive an embryo, and so that it should implant normally. So with that then, with the blood test and ultrasound scan, we meet back shortly after that, and I quite strongly advise that the partner in that time goes off and has a sperm test. So we've done an ultrasound scan, a blood test, and a sperm test, to see me back in 2 weeks' time to actually go through all those tests so that we can come to a diagnosis or a path through fertility journey. The only other thing that I haven't spoken about is that we do tubal testing as well. And tubal testing is incredibly important because the sperm and egg have to get together. And they do this via going through the cervix, up through the uterus into the tube. The tube has to be open for the egg to get in, for the sperm to fertilise it. So I think it's really important to be able to assess that, and we do that within 1 or 2 visits, maybe 3 visits after we get testing going and working out where we're going with treatment. And with that then the tubal testing is done by a tubal patency test via an outpatient department, which is just downstairs from a room which is called a hysterosalpingogram, where salty water is pushed through the tubes with a bit of dye and make sure the tubes are open. That can look at any intrauterine issues or polyp issues. And the other way to make sure the tubes are open is to a laparoscopy. And certainly one of the other things that we can look for in secondary infertility is regrowth of endometriosis, which needs to be excised via laparoscopy. Basically, when we look at dietary issues, then there's one diet that does have a negative impact on fertility, and that's the ketogenic diet. So if you actually go on the protein-rich, low carb, low sugar, protein-rich keto diet, then what will happen is your body will go into ketogenesis, which is producing lots of, breaking down lots of fatty cells, and then ketones are the product of this. You'll actually smell that in your urine if you're actually doing the diet properly, and with that, that can have a negative effect on your ovaries and the follicles developing within. So you certainly don't want to do a ketogenic diet within 3 months of you trying to fall pregnant. Other than that, just a healthy eating with a modified caloric intake, not less than about 1,400 calories, and down to 1,200 calories would be okay, but under the auspices of a dietitian would be even better. With the weight in fertility, the higher the BMI goes, the more estrogen you have in your fat cells throughout the body. That thickens up the lining tissue of the uterus too much, and that can cause early miscarriage. It doesn't increase it substantially, like it doesn't increase it by 50%, but everyone has a miscarriage rate of around about, there's a big movie around at the moment, about 1 in 4, let's say 25%. So with that, then if you're quite heavy, it might increase it to 30%. So it's not a massive change, but it does increase your risk for miscarriage. It increases being heavy, does increase your risk of diabetes and high blood pressure in pregnancy. So it's something that you want to get under control before you get pregnant. But for fertility, the estrogen secretion by your fatty cells stops you from ovulating properly. And so with that, then you may only ovulate every second cycle or may not ovulate at all. So I think with that, then just trying to get your weight down below 30. And I think my counselling is always about not to be punitive about weight, because I carry a little bit of weight myself. If you could just get down even 5% of your body weight, that has a significant effect. So I think I always look at it from a positive point of view. Can you do 5% of your body weight? And so if you're, let's say 90 kilos, then that's only, you need to lose 4 kilos to have a massively better effect on your fertility and your pregnancy in the end. So I think being positive about it and setting goals that you can achieve is probably a better way through to make sure that you're going to be able to get there, because you don't want to sort of say, I want to lose 20 kilos and stop after 4, when you should be patting yourself on the back after 4. Certainly the work stress, Danielle sort of asked, work stress can be an issue, and I think with work stress, what it can do is actually it can make you secrete hormones from your pituitary gland in your brain that actually turns ovulation off. I've had professional athletes that can turn their ovaries off with lots of running, and I've had professional women with highly stressed jobs that can turn their ovulation off. The duplicit thing that we can do is we can make you ovulate even though you've got a stressful job. So whatever you're doing, we can make you ovulate, but it's sort of a little bit counterintuitive. How about you get your job a little bit more de-stressed, or if you can't, you can come and see me and we can talk about how to stress manage and make you ovulate both at the same time. So I do think you need more investigation with that, because simply just monitoring your cycle with ovulation monitoring, which is via blood tests and ultrasound scans on the correct day of the cycle, maybe day 10, 11, 12 or 13, any of those days you could come in for an ultrasound scan and a blood test just to see if you're actually ovulating correctly. A week later we can do another blood test to say, yep, you have ovulated, everything's fine. And we can actually advise you the right time to have intercourse in those cycles as well, to make sure that you're having intercourse at exactly the right time, not every second day for weeks on end. Because literally one of my patients asked me a couple of weeks ago, is she allowed to have intercourse in my, once she was pregnant? And I said, of course not. I'm a fertility specialist. You can only have intercourse once to get pregnant. That's all you need to do to have intercourse to get pregnant. So I'm getting a bit old, so I suppose I didn't see the sinister nature of that, because she was in a young relationship and intercourse is the natural part of the whole process. But I think with that, I think the ovulation, the point of ovulation is the time you have intercourse during the cycle, so we can predict it so closely and so precisely that literally you have intercourse the night before you ovulate, the night of ovulation, and that gives you the best chance. The best chance in any given cycle, as I've said, is only a 1 in 4, 1 in 5 chance. So it is not a high level of success, but it is a 1 in 4 chance. And if you're that 1 in 4, you're pretty happy with yourself after that. So with the other issues with coming along to see me, I've talked about when you come along to see me about after 35 and at 40 years of age, then certainly it's something that can be quite a straight away sort of consult, because I think what I do is actually give you some information about AMH, and with that, the AMH is the ovarian reserve test, and if you're over 40, then that's very important. I saw a patient not too long ago that was 39, and her AMH is quite low. She didn't realise that, and she's freezing her eggs now because she doesn't have a partner. So it was just just a fertility check to make sure she was well. We found out that she had poor ovarian reserve, and now she's doing something about it. So it's great helping women to empower themselves to take reproduction into their own hands, so I can help them with that and be a part of the solution, and not the frustration of not being pregnant. Certainly ovulation predictors can be helpful, but if it's showing that you're not ovulating, is that in a ovulation kit predictor, or is that an app that you're using to track your ovulation? And if it's a predictor kit, they're very accurate. They can be a little bit confusing. We don't use them here in the fertility test. For fertility group, we don't use them here for a test, because we've got turnaround times of 2 hours for our blood tests, and blood test tells me, one, is your follicle that's going to ovulate, is it producing enough hormone? Is that hormone level high enough to grow a good lining tissue? And are you having an LH surge, which is above 50 or so? And so that means you're going to ovulate tomorrow. So we can tell within 2 hours of you seeing us on the right day of the cycle that you're going to ovulate tomorrow or the next day. So that's very helpful. I think if I had my way, everyone at the age of 30 would have an AMH, especially if they're a busy woman and they're not thinking of having a family soon. Certainly, definitely by 32, because I think if you haven't had a family by then and there's not a family in the near future, then I do think it's best to have your first child before 35. And if you're not going to do that, really put yourself in the driver's seat rather than regret. Because I did see a woman at 33 who came in just to have a check of her fertility. She was going into menopause within 2 years, so we did 3 IVF collections by 35, and she was managed to collect 23 eggs over 3 cycles. So she was very happy with that, and now at 36 she's menopausal and has got her family or potential family on ice with 23 eggs collected. So as soon as she finds the right man, she'll be back, I presume, but that hasn't happened yet. So I would think at least 32, and if it was my daughter, I'd advise them at 30, because literally the test costs $95. It's back within a day, and you can say, well, if it's average, then never think about it again. If it's low, then you've got a fair bit to think about. You don't have to do anything, but you can at least be empowered by the knowledge that your ovarian reserve is low, average, or have the knowledge if it is low. And the AMH test, how if you delve into it a little bit more, of the little antral cells that are in the ovary, it actually picks up the markers on how many eggs are left in the ovary and when you possibly go through menopause. So we graph the numbers out, and so we put you in a graph to say, well, yeah, if you follow this trajectory, then you're going to go through menopause 5 years early or 10 years early, or on average. And so it looks at a specific hormone, the anti-Müllerian hormone, is secreted from the ovaries, the bed of the ovary. So it's really high-powered test, but for $95 is certainly worth doing. And as I said, from 30 or at least at 32. So it's a little. I think also I'd like to mention, as I've actually looked after a lot of patients with secondary infertility, I do find the biggest issue that patients face is the psychological impact. And what I like to do is to say, well, come and see me, let's go through this together. You're not alone. There are a lot of women that actually come in who have trouble falling pregnant after their first child. And quite often what I find is that it's actually a timing issue. It's as simple as that. In other words, we can just track down the ovulation. You might be ovulating day 8 of the cycle rather than day 14. And if that's the case, then we can actually detect that and tell you the right time of the cycle to actually fall pregnant. So you come in for an ultrasound scan and a blood test at the right time. You give us a call at lunchtime, and we tell you when what we call do homework or intercourse. And basically that's as straightforward as it gets. And most people with secondary infertility that haven't had a primary cause for fertility can get pregnant with ovulation monitoring. If your ovulation is turned off for some reason, we can turn it back on. And we've got medications, tablets and or injections to actually make you ovulate as well. So that can be quite helpful with the whole process. So I think it just gives you the knowledge to say, 1, you are ovulating; 2, that the sperm is normal; 3, that your hormone levels are all fine, the uterus and the lining tissue are all normal. So it puts you in the driver's seat to say that everything is going well for you, and there's not an obvious problem. Because literally, if we've tried ovulation monitoring and you're not getting pregnant after 1 or 2 cycles, we'll go ahead with the tubal patency test to make sure the tubes are open very quickly. Because say for the person, the young lady who dialed in about being 25 and not being able to fall pregnant for 2 years, then I'd be really wondering whether or not at that stage, if you've been trying for 2 years, you'd be sent off for a tubal patency test very quickly, because literally we want to make sure the tubes weren't sticky and have something sort of blocking the tubes, because that'd be something that would be an issue. And if ovulation wasn't confirmed on the testing, ovulation wasn't confirmed on testing, we'd do something about that as well. Certainly with men and secondary fertility, men are a little bit easier than women to investigate, because basically all we need is a hormone test, and mostly they come back normal, although secondary infertility in males can be due to hypothyroidism. I diagnosed just recently one guy who had no thyroid hormone floating around in his body, and he's now treated with these thyroid tablets, and his sperm counts got back to normal. Pituitary issues can be an issue, and stress-related pituitary issues can be an issue with secondary male infertility. But as we look at the sperm count. There's not a lot we can do with a lot of sperm counts. Certainly taking multivitamins can be helpful with doing the prior to the testing, and we do a sperm count and a hormone analysis, and with that can be all sorted out within a week to see you back and go through that. The sperm's assessed the sperm count's assessed in 3 different ways. It's by motility, by number, and the anatomy or the morphology of it. And so with that we can work out what's the best way forward. The issue, if the sperm's not working now and the sperm was working, then often that can just be an age-related issue as well. So heat stress can also affect the sperm. Wearing tight underwear, doing lots of cycling can affect fertility issues as well. And secondary infertility, if your husband's taken up heavy drinking or smoking, that can negatively affect fertility as well. With waiting, then basically I've just got a question about, do my chances to conceive with the second child the longer we wait? Well, unfortunately, yes, because one of the prognostic or the indicators for success is how long. Well, number one is your age, and number two is how long have you been trying. So if 80% of you should be pregnant at the end of 1 year and 92% should be pregnant after 2 years, that means you're down to each cycle probably less than 2% chance. So that's why I say if you're under 35, you should come and see me after 12 months. And if you're just under 40, then in 6 months, and over 40 virtually straight away. So the chances do decrease cumulative because you've had negative tests for so long. So that can be quite hard to hear. But again, if there's an issue with ovulation, which most probably is the case, and we can turn it back on, and so your chances get back up to 1 in 4, 1 in 5 per cycle again. So you can sort of turn everything back on and resurrect your cycle status. I think with secondary infertility too, one of the big issues with secondary infertility is the stress that it causes. And I think not only are you sort of dealing with the ups and downs of normal life, but you also have got a little one at home, and this also, trying to fall pregnant adds to the emotional fallout that is unique to someone who's had a baby who's trying to have another baby. I think it's helpful to address these psychological issues and feelings, and I think when dealing with secondary infertility, it's very common to feel shock and denial. After all, one baby might have been straightforward for you, but you probably should have assumed that the second one would have been easy too. But secondary infertility is more than just most people realise, and to allow yourself to the chance to accept the idea that you may be dealing with secondary infertility is really helpful, and it actually gives you the opportunity to come to terms with it. I think once you've accepted it, then you can then move on it. You can come and see me, we can help you. You can come and see counsellors, which can be very helpful, because I always say to my patients, you don't want to be seeing me for fertility treatment, you just want to be pregnant out in suburbia. But if you come and see me, what we're going to do is actually assess you, make a diagnosis, and then offer you treatment. It's up to you what treatment you have, whether it's just ovulation monitoring, or timed intercourse, or insemination, or IVF. So they're the gamut of treatments, and quite often it's just a diagnosis process that allows you the pathway to grieve this whole loss of getting pregnant quickly. And we've got counsellors here at Queensland Fertility Group who are excellent at counselling you about reproductive issues, and they're very, very helpful, and they can sort you out in that sort of headspace. So I think it's just as important as seeing me as to seeing the counsellors as well to help you through all this. Although I get on pretty well with my patients, so that I can actually help them, I think, on a lot of ways as well, because I want to be part of the solution and part of their fertility journey in a positive way. So I try and do that with all my patients. So are there any other more questions at the moment? I think we're coming up to about 7:30 now. So I'll just see. I'll just make sure I'm not missing any questions here down that side. Sorry, I'm just checking it out there. So if there's no more questions, I think basically again I'm Dr. Shane Higgins at Queensland Fertility Group. You can either contact me for further questions or consults at my rooms at 55 Little Edward Street, or you can go to the website at queenslandfertilitygroup.com and .au, and you can access the 1-800 number from there as well. So might be steering you up the wrong path to if I if I give you off the top of my head. So just go to the website qfg.com.au, and the 1-800 is the number on there to do it. Well, thanks very much, everyone. I appreciate your feedback, and it's my pleasure to talk to you. Hopefully I've been helpful tonight, and I'm very passionate about giving you guys the best chance of falling pregnant. So come and see me, and as I said, I deliver my babies at the Mater Mothers Hospital, the best baby hospital in Brisbane. So it's the only place I go. Okay, well, thanks for your time this evening, and I'll sign off. Thanks very much then. Bye now.